okay, then I take this opportunity to invite Dr. Ajay Aurora, a prolific vitreoretinal surgeon from Noida. He would be speaking on a topic, Widefield imaging in diabetics. तब तक आप सर को दे दो अगर टाइम लग रहा है वहाँ जाके चेक कर लेना पड़ेगा ये ले
Okay, so just to add on to what was just said about the problems related to the limitations, I find only one limitation with Mirante, and that is when you are taking a disc photograph and you want to, especially for the glaucoma colleagues, because it is pseudo colors, you may not get the exact color. So when you compare the disc to disc photographs, then that's an issue. So I have kept my old fundus camera with me, but if you, there is a scale below on the Mirante where you can adjust the colors. And when you adjust those colors near to what you would get in a normal fundus photograph, we have to do it initially. And once you do it initially, then all subsequent photographs with the same color combination would come out safe. So that is the only trick which is useful. So I'm talking about Widefield imaging of diabetic retinopathy, and I think this has already been mentioned to you as to what are the various, the evolution of retinal imaging from the first fundus camera, which came out in 1926, to where we are today. And what is the definition of ultra-wide field imaging? So one line which was said by Nathan Chaudhary, he said, a single capture image which provides a view of the vortex bands in all four quadrants and beyond, thus meeting the wide field and ultra-wide field definition, would offer enhanced efficiency in a real-world clinical setting. So that should be the aim of, so there are numerous cameras available, but if I can get all the four vortex bands and a little beyond, that is ultra-wide field imaging. So this is what happens when you see with slit lamp, when with the indirect ophthalmoscopy, with a fundus camera, with a wide field imaging, with the ETDRS 7 standard charts, and with a wide field imaging. And if this was a study by Jocelyn Ailo et al., which showed that they were missing 10% of the time peripheral lesions, which would have changed their protocol for treating a particular case of diabetic retinopathy. Similarly, the peripheral non-perfusion areas, especially in cases of Behçet's disease, when we do a Behçet's disease, the pruning of the peripheral vessels, the problems which you get of peripheral areas of non-perfusion are all picked up on a wide field imaging. So this is what Mirante looks like. I will not go into the technical specs, that it has got a quadruple frequency 4 lasers so that it gives you a color depth imaging. And please, this is one thing which we must keep talking repeatedly. What is the angle which they talk about? What is the Optos angle? What is the Mirante angle? So let me come to it. If you draw a straight line, which is 180 degrees, they always say it gives you a 200 image. I have gone back to them and asked, how come you get 200 image which is beyond that 180 degrees? And nobody is able to answer that to me. So the Optos angle for Mirante is 160 degrees, which actually is in real degrees 110 degrees. So this is a normal image on a small pupil. This is how a standard image looks like of Mirante, and this is what a wide field image looks like of Mirante. And here, as I said, uncooperative child, 7 years old, did not allow me to do an indirect ophthalmoscopy, and we were able to pick up. This is to document peripheral lesions. I'll go on to my talk on diabetic retinopathy very soon. So I'll present you 3-4 cases where actually changed the way we were treating our patients with diabetic. So this was a patient who had vitreous hemorrhage in his left eye, subsequently had a hemorrhage in the right eye, underwent vitrectomy with silicone oil injection. His visual acuity improved. He underwent a silicone oil removal, and then he had a recurrent vitreous hemorrhage. We allowed the hemorrhage to absorb, visual acuity improved. He had a fresh vitreous hemorrhage. We had taken him for vitreous lavage, did a fluid gas exchange, And at that stage, after the fluid gas change, I did this imaging. Now you can see here on this imaging, we had missed out a peripheral NVE, we had missed out large capillary non-perfusion areas. I went ahead and lasered that patient in the periphery. So if it was not for this, if I did not have a Mirante, what would I see? I'll just see this much of the fundus. But what I saw was this. So there's a difference between what I could see on a normal fundus camera and what I could see on Mirante. So this patient, we went ahead and lasered, and this is what the patient, we had lasered him adequately. And now I have followed this patient for last 18 months, and he's doing well. He's not had a recurrence after that. So it's 21 months, sorry. So then we treated the same patient in the right eye. He had similar pathology. You can see a large area of NB in the periphery. We went ahead and operated. We lasered these areas. This is just to again show you what we would have missed if we had done a normal standard imaging. And this is how it looks. This is another case who had, who again came to us with a recurrent bleed. And normally looking at you will say, oh, you had so much laser, how can you bleed? But she did. There was a large area of capillary non-perfusion. She had a small NVE. We lasered that. This is what I would have seen on a standard photograph. This is what we saw on a Mirante. And that's how we went ahead and lasered. Same patient in the other eye, retina was more than adequately lasered. Why she's having a vitreous hemorrhage? Again, we saw peripheral NV, which I would have definitely missed if I had done a normal fundus camera. So you see, this is what a normal fundus camera would reveal. This is what Mirante would reveal. So went ahead and lasered it, and this patient is again stable. Another patient who is, this is the area of capillary non-perfusion. This is the patient who was referred to us as a MACTEL. Actually had vasculitis, large area of capillary non-perfusion. We treated the patient did well. Another patient who is 44 years, type 2 diabetic, again had been lasered before, went ahead intravitreal injections, good metabolic control. On April 22, did pars plana vitrectomy with extensive membrane surgery with oil injection, and this is how this is what the patient's angiography was. The areas of capillary non-perfusion. We went ahead and lasered those areas. Same patient in the other eye. He underwent surgery in this eye as well, and this is what the patient looked like both in right eye and left eye. So to conclude, the Widefield imaging gives us better images even when there is some amount of cataract, entire retina is covered. It helps us in young, uncooperative pediatric patients, patients with small pupil. There is simultaneous imaging of the central and the peripheral retina. We can, as mentioned earlier, we can do an FA and simultaneous FA ICG. Fundus autofluorescence with both green and blue autofluorescence. And we can also take IR images where there's no flashlight. So therefore, the take-home messages, it has been documented that ultra-widefield imaging in diabetic retinopathy is non-inferior to the ETDRS standards, 7th standard charts. Ultra-widefield imaging of the periphery diagnoses more lesion than those detected by the ETDRS screening, and has been shown to change the diabetic severity scale in about 10 to 12% cases. The diabetic retinopathy cases, when imaged with the ultra-widefield, FA, the risk of development of PDR are very high, and then there is 118.2 disc diameter non-perfusion area. So if you detect such large areas of non-perfusion, you should go ahead and laser them. Lasering the periphery non-perfusion area may reduce the amount of anti-VEGF required in cases of DMA. Our experience of lasering the periphery non-perfusion area in cases of PDR has been very, very helpful. We have been able to, patients were having recurrent vitreous hemorrhage. Since I bought the machine, my incidence of recurrent vitreous hemorrhage in these sort of patients has certainly reduced. So this machine can allow us to see it, show it to the patient, and treat it adequately. Thank you for the opportunity. Thanks a lot.
Thank you, Dr. Ajay, for an excellent presentation on the usefulness of Widefield imaging in diabetic retinopathy. As you said, even I follow that post-operatively. I do keep doing an angiogram, which is many a times fruitful. And recently, the trend is towards doing an angiogram early in the course of diabetic retinopathy, especially a Widefield angiogram, to see for capillary non-perfusion areas. At least you can stratify the patients on how frequently you want to follow these patients. one with larger capillary non-perfusion, probably you follow them up very closely than the one with a lesser area of capillary non-perfusion. Thank you very much. Here